All right, good afternoon, everyone. I'll quickly introduce myself. I'm Tom Munier with the Office of HIV/AIDS in Washington. I'm glad everyone's got a nice full belly. We got a nice dark room, so hopefully the mood is right to talk about the clinical cascade. We're going to go through, and I'll mention these are the 5 areas we're covering, just sort of care and treatment, adult care and treatment overall, PMTCT, pediatric and adolescent care and treatment, testing, and our programs for our key populations. I'm going to focus a little bit, we don't have new COP guidance out yet. However, I'd like to focus on things that are likely to be in the COP guidance or get a little bit more emphasis in the coming year. So there's nothing formally written yet. We don't expect significant changes to the COP guidance, but there may be more emphasis in certain areas when we have COP deliberations in the coming months, early next year. So with that, on the treatment side, I want to stress that there's actually a lot of good news, and there's not going to be too many changes. We've seen that, while COVID did interrupt services globally writ large, our PEPFAR treatment programs were remarkably robust, and I think it speaks to a lot of the great work that a lot of you have done. Our viral load suppression as an agency, when you roll it all up, is now close to 95%, which is fantastic. Interruptions in treatment have fallen down to 2.5%. So we've been able to keep this progress going through COVID and through these interruptions. So we don't anticipate a lot of changes that are coming up, but there are going to be some targeted opportunities, for lack of a better term, to take advantage of. And part of this is that we're entering a new phase in PEPFAR. We're going to have a new reauthorization soon. We have a new PEPFAR ambassador, and many countries are reaching the 95, 95, 95 targets. So between this and the fact that the COVID pandemic really, I think, stimulated more use of technology in patient care, we have the ability to better individualize care. If the old paradigm was a public health treatment approach, the same type of thing for everyone, we're now getting to reach those last gaps. We need to actually individualize care to make sure that it keeps everyone consistently engaged. So one of the areas that I think is an opportunity, and this is something that I think most of you are already doing, advanced disease programming really got reinvigorated probably a year to 2 years ago, though it's still at a fairly limited scale. I'm not going to go through all of the elements here, though I think these slides should be made available at some point, so you can go through them if you're not familiar with them. The one I would like to call your attention to on this slides is the idea of a death audit. It sounds like a very creepy term, but this could be actually quite helpful. This is perhaps taking a sample of facilities and taking a look at the reasons that people have died, our clients living with HIV. This gives us insight into 2 things. 1, where the system is failing them, and 2, it gives us a sense of the patterns of morbidity and mortality that are affecting our clients living with HIV. And that's going to be helpful a little bit later when I talk about integration. But I'd be remiss if we were talking about advanced disease without emphasizing the importance of TB in this. This accounts for 50% of those who die from HIV-related causes. They die because of TB. We've actually made good progress, I think, in TPT initiation, TPT completion, and even we're seeing steady upticks in the use of molecular testing like GeneXpert. The one area where we seem to not be making as much progress is down in the red here, which is the case finding piece. Our TB team back in Washington did a nice modeling exercise that actually suggests we're probably missing about 200,000 people living with both TB and HIV who eventually go on to die. And so this is definitely a missed opportunity. WHO came out with new guidance about 1.5, 2 years ago. Apologies if I'm off, just because my sense of time was skewed post-COVID. But that emphasized, for instance, computer-aided radiography, which can help increase the diagnosis, along with the urine TB LAM testing, which I think we're beginning to roll out in many settings, but is wonderful for picking up particularly non-respiratory TB. in our clients. Cervical cancer, very similarly, has a new frame on it in many of our programs, at least those of you that are implementing cervical cancer screening for women living with HIV. We had sort of a screen and treat. You'd do a visual inspection with acetic acid, and if you see a lesion, you'd treat it with cryotherapy or LEAP or something. But we want to introduce another step. And this is the HPV testing component. So you first do this screening test with HPV, and then if that's positive, then you do the VIA and the treatment. But the challenge with introducing this step, the beauty of the simple screen and treat, VIA approach, was that you have the woman there, so there isn't that opportunity for loss to follow up. With this HPV test, it's another a molecular diagnostic, so it's similar to TB, to viral load, EID, COVID testing. It all gets used on that same platform. So as countries move into this, we want to make sure that there are 4 things that happen. One being that linkage to treatment is strong. We're seeing that improve. That the lab infrastructure is optimized such that you can get that result back, and that there are good SOPs to ensure quality VIA and systems for making sure that those results get tracked for the client overall. So hopefully this is something we can do more of in the upcoming year. Now, I spoke a little bit earlier about integration. This is something that may be completely new in the COP guidance. In several of Ambassador Nkengasong's presentations, he has interestingly stressed 2 areas: hypertension treatment for our clients living with HIV and mental health. And I'm going to speak a little bit more on mental health in a minute. But I think there is definitely an opportunity here. I think we realize there's no, I can't say there's no point, but it's frustrating to have someone doing fine with their HIV only to have another condition lead to an episode of morbidity or mortality. And so we want to make sure we take care of the whole client. This is going to involve some creative thinking, and this is where I hope as partners you're engaging with your USAID mission counterparts, especially over the next couple months, to figure out where those targeted opportunities for integration might be. I got to be honest, it's impractical to integrate everything everywhere. That said, if you think about what's needed for a client living with HIV these days, you need to have access to 1 pill once a day, and you need a viral load test once a year. It's very simple. It's not the old, the old days where we'd have 3 different drugs sometimes and many, many side effects. And as a result, we can potentially integrate HIV services into outpatient departments and routine primary health care. I mean, it's quite simple. As long as you have the ability to access higher level care if you need it, most clients won't need it. So it'd be good to think through where this could happen and how it might happen, how community health workers can be involved, et cetera. So it's a very exciting area, and I think one we can chat more about if there are questions. I did want to stress the mental health piece. This is one I'm really, really excited for, if for no other reason than it's been relatively ignored in PEPFAR. I hope I'm not being too controversial by saying that. We haven't really done a very good job. And some of this is due to the fact that, truthfully, treatment paradigms have not been optimal. For instance, in the United States, where I've done a lot of my work, we tended to have a very drug-heavy approach. It turned out those drugs don't really work all that well anyways. There's an important social component. We are primates, and as primates, we're always social creatures. And where this presents an opportunity is the fact that we have fairly robust community-based programming that we can leverage to tap into maybe not the most significant or severe mental health conditions, but for the overwhelming majority of people with depression and anxiety, there's a lot that we can do. I've got 6 different models here, and we can go into some of the specifics, and I can share perhaps more presentations if you want to think through what would be best in your element, but it really will be a new area of emphasis. And I think this will help us reach a lot of those folks who have been hard to reach otherwise. And that cuts across age, gender, disags. The ones that are hard to reach, in many cases, have mental health issues. This is an example from our partners and team in Uganda. Another thing is we've done a great job rolling out differentiated service delivery models. MMD, DDD, CAGs, adherence groups, family-centered services, et cetera. One thing that we found interesting in this exercise they did, they just asked folks if they were in the model that they wanted. And this is about individualizing care. And while a lot of people were in the model that they wanted, we actually found that a decent number, like 20, 30%, weren't. And if you actually put them in the model they wanted to be in, they had lower rates of interruption in treatment and higher rates of viral load suppression. It's kind of not surprising, but I think it just highlights that life circumstances change. And so a lot of times when we roll out a new model, we enroll people in it, but then we don't think to sort of reassess, is this really where you're at right now? You know, sometimes someone could be doing fine with MMD, they lose a life partner and are having trouble with other issues, and so they need that sort of support group or that new model. And so periodically assessing this as part of our programming, I think will actually increase our rates of viral load suppression and reduce IIT. It keeps folks engaged. And then this is just a quick plug. When we tend to talk about women living with HIV, a lot of the conversation is around pregnancy. However, if you look at just the absolute numbers of people who are lost and disengaged from care, and they may come back, there's this failure that happens, and it really does affect a lot of women, particularly in the age range of 30 and above. And if we even make a 1% decrease in our IIT rates here, it actually offsets all of the IIT 25 and below. I mean, it's a significant amount. And there's been interesting literature that the needs for some of those clients may be different than what we're thinking about. For instance, there was a study in Malawi that actually spoke about elder care as one of the barriers for women being able to access treatment. And these aren't necessarily the types of barriers that we've been thinking about and assessing. So I think I'd like to stress that this could be an opportunity to do some qualitative work and research to really understand, for women who do disengage from care, what it is that causes that and what we might be able to do, what service delivery models might fit them best. And then we've gone from the opportunities to the fundamentals here. This is something everyone, I think, has already done a pretty good job. There's only a couple of countries that I think are lower than 90% for TLD rates, and you know who you are. I wanted to actually preface that this is probably less about COP guidance and more about where the WHO guidance may go in the coming years. One thing we've found with TLD, and apologies that these slides are a little bit small here, when in all of the clinical studies of dolutegravir and the integrase inhibitor class, you'll have about 10-ish% of people who will develop a high viral load. And in all of them, almost zero, I mean, it's literally like 0 point something %, have been because of resistance. It's purely the ability to take the medicine consistently. And that's usually driven by factors other than the drug. It's not necessarily side effects. It may be food insecurity, inability to, disclosure issues, other things that are affecting the client. But what this has led us to realize is that, honestly, it's less about the old thinking of lines. First line, if you fail that, then you go to second line. If you fail that, then you go to third line. That's kind of outdated thinking nowadays. We want all of our first-line patients and second-line patients, the way that we used to think of it, on TLD at this point. Even if you're failing that tenofovir component, those folks do better with tenofovir than they do with AZT. So TLD is the way to go for a lot of people on second line as well. And what they're probably going to move towards is more options. So thinking about it as, you have clients coming in, you'll have a very small amount that do have side effects to TLD, and their option will be a protease inhibitor-based regimen. But basically for everyone else, it's going to be TLD. We're trying to figure out how long people can go with suboptimal adherence and still remain stable on TLD. For many clients, it's been several years. With intermittent viral load spikes and no resistance. So just want to stress the two things to keep pushing forward is the pediatric transition. We want to get all of those kids who are eligible on dolutegravir, and then, of course, all of our second-line clients on dolutegravir as well. And I think we're moving in that direction, which is great. Viral load coverage is one of the things. I won't speak too much to it. We've done such a good job seeing every other indicator seemingly go up, except for viral load coverage, which is kind of hovered in the 70%-ish range. For us globally, I think some countries like Uganda have done a better job with this and are closer to 90%. But I think one of the things I'd like to stress, and there were a few really interesting abstracts here at the partner meeting, is taking the viral load services away from the clinic and to the client. So sometimes having the ability to draw bloods outside of the clinic is a nice opportunity for those people who we accidentally miss because when they came in, we forgot to draw their blood, or for some other reason they've disengaged. It just makes things easier. You'll see that coverage go up. And of course, is the last thing, all of those core things that we've been doing for years still remain important. Rapid initiation, offering a range of service delivery models, the community-based support, you equals you messaging. But truthfully, I feel like a lot of you are really doing this quite well. It's a question of just continuing to refine them and making sure in areas where things aren't working, you sort of work on that. Because we're seeing all of these indicators go up. So again, I want to say thanks to everyone. Please don't stop what you're doing. And I used this slide last year, I think, at this time, because it just sort of highlights the fact that we really do want to move from that public health approach to more of an individualized approach to assessing all of our clients to figure out how they want to receive services and what those specific barriers are. So with that, I'm going to turn it over to Mina Srivastava to come up and do our next section.
Great. Thanks, Tom. That's a hard act to follow, and you were actually perfect on timing. We were commenting on that. And so I'm probably going to go over, because I have both PMTCT, even though Tom said we should talk about non-pregnant women, but I am going to talk about pregnant women and breastfeeding women and children and adolescents and families. So that's a lot to cover in 15 minutes, but my co-presenter said I could go a little bit over. I think I got permission. So sorry for some of you in the PED session yesterday. These are a little bit slightly repetitive in the beginning, but then we'll get into some of the new priorities that are probably going to be coming up in COP23. And I'm sorry, I didn't introduce myself. I'm Mina Srivastava. I'm in the Pediatric Maternal Clinical Branch in the Office of HIV/AIDS, and so I'm really excited to be here with you all. We know we've made a lot of progress in PMTCT, and I feel like in general we've hung our hat on PMTCT and think that we're done, but we're actually not. We've definitely reduced new child infections, and I think the visual in the middle, as we've scaled up ART for pregnant women, which is at about 80% now, our new child infections have substantially decreased. But we still had around 155,000 new child infections in 2021, which I said yesterday, far too many, so there's still a lot of work to get to elimination. And I think the visual on the left, really good UNAIDS data that our team is trying to use with all of our country programs and our partners, shows what's happening to pregnant moms. Are they getting diagnosed? Are they on treatment? Are they virally suppressing? And then why is a child getting infected? And so that data on the left breaks it down, and a lot of our reasons why children are getting infected is because mom's getting infected during pregnancy or breastfeeding. She has a high viral load and high likelihood to transmit to her infant, or she did not get on ART and stay on ART. And so I think these are things that we have to think about looking at this data by country and figuring out how we're targeting those moms, even though we have really good testing and ART coverage in ANC. The visual on the right, again, when we look at PEPFAR data, our 2-month EID coverage and maternal to child transmission rates, we're doing a pretty good job, but I think when you look at things globally, it's not so great. And we're at about 61.8% EID 2-month coverage, and our maternal to child transmission rates are still around 21%. But many of the countries that we support are much lower than that. But I think that when you think about PEPFAR versus non-PEPFAR sites, usually we do really well in our PEPFAR sites, but our non-PEPFAR sites sometimes are lagging behind. So I know that we're really trying to think about how we can provide TA and make sure there's an equitable approach so that like all infants, all pregnant moms are getting the care that they need. Moving to children, 1.7 million children living with HIV less than 15. On the lower left visual, you see our ART coverage is at about 52%. It's plateauing. A lot of our countries are kind of plateauing as well. And in the upper right, this is a visual, like basically when we look at our pediatric treatment gap, most of the children are in these 20 countries, with South Africa, Nigeria, DRC, Tanzania, Kenya being the top 5. So again, a lot of focus in these countries to diagnose children, in a timely manner and get them on treatment as well. And that's where our branch really focuses in on these countries as well. The lower right, this is me trying to fit like 4 slides in 1 slide. But again, children lag behind adults in terms of the 95, 95, 95 cascade, and we know that. And so I think that we still have to continue about how we're reaching children and what that approach is. You've seen this visual probably a lot this week, and I'm showing it to you again because Pillar 1 really speaks to children. And so we're really excited that OGAC and Ambassador Nkengasong has put this forth and showed this commitment. And yesterday I told you all about 2 big global initiatives that got recently announced this past year, accelerating progress in PMTCT and pediatric HIV, which is AP3. We have 7 priority countries for that, that PEPFAR will prioritize our support to with a little bit of money that came in COP22 to some of your countries and some of our partners, and you can see what the objectives are. Then over the summer, UNAIDS announced the UNAIDS Global Alliance to End AIDS in Children, which was really exciting. And they have 11 countries. Those are highlighted in red and blue, and there's some overlap with AP3. And I know that at OGAC, our PEDS lead there, Hillary Wolf, we're really trying to make sure we coordinate our AP3 and our UNAIDS Global Alliance with our government colleagues and with Ministry of Health, so we're all kind of aligned around the priorities and what we're planning. So I'll move in a little bit into the technical part and program part. Really what's emerging when we think about, and I'll be honest, I used to work for Baylor, and I always give a shout out to Baylor where, we do a really good job, and PEPFAR does. Like if you have HIV, we'll link you to treatment, we'll try to support you on treatment, but I think just thinking about back to the prevention side of things, and I've tried to shift my mindset back to pregnant and breastfeeding women, and how do we reduce new infections in those pregnant and breastfeeding women? And then if she does get infected, how do we get her on treatment and suppress her so that she does not transmit to her infant? So there's a lot more renewed focus now on maternal retesting. So even though moms come in and we've got good coverage at ANC1 for testing, she's negative. She might be high risk for various reasons. Often what happens is that mom might then go on throughout a period of pregnancy of 9 months, breastfeeding for 2 years, and never get tested again because, oh, you already tested negative at ANC1. She could get infected with HIV, and that's where we're seeing a lot of new child infections, where mom gets a primary incident infection. And so we really want to focus on retesting throughout pregnancy and labor and delivery, and our PEPFAR and WHO guidance is ANC1 at labor and delivery and 6 months postpartum. That's the bare minimum. If moms are more high risk, female sex worker, other kind of risk factors, they should be testing obviously more frequently. Now OGAC and in our COP guidance, there's going to be a lot of focus on maternal retesting and linkage to PrEP as well. So a lot of countries are rolling out PrEP. We want to make sure that pregnant and breastfeeding women get included in that too. And so I'm going to actually skip kind of going through all these visuals and data. You can look at them later. But we are collecting this data through our custom indicators and posting in C1 data. And right now what it looks like is when a mom tested ANC1, our reported data looks like we're retesting about 30% of them. And I will say our USAID data shows every quarter between 5,000 to 9,000 women have a new, are getting diagnosed newly as a new positive during pregnancy, and she's at high risk of transmitting to her infant. So I can't stress enough in your COP plannings and with our local partners and everybody really thinking about what we're doing for retesting and PrEP as we move forward. And again, if mom gets infected, then again, obviously we want to make sure we get her suppressed. Viral load testing, our data on viral load coverage in pregnant women is a little bit all over the map, and it says 24% here for USAID. I don't think that's true. I think we all know it's difficult to capture a viral load test for a mom when she's pregnant for 9 months, and then you have to make sure you report it properly, and then it gets reported the next quarter. So I'm not sure that I believe the 24%, but at whatever it is, we just want to make sure that we are, if moms are on treatment, that they get a viral load test, and we make sure that they're suppressed, and so that we reduce transmission. With U equals U messaging, I think it's always been very much tailored to non-pregnant adults and KP. It also is applicable to pregnant women too, and think about U equals U so that she doesn't transmit to her infant as well. So I think we also want to make sure that we're emphasizing that in our programming too. I say yesterday I was repetitive and I was a broken record, and I'm going to be one again. USAID has the majority of our OVC and KP programming, and we want to keep it that way. We have such a unique and amazing community platform to reach children and provide them really with comprehensive facility and community-based services. So I really love the visual, I think, on the right that just shows thinking about KP, if they're parents, if they have children at home, if they need PMTCT services, and then those children also getting linked up with our OVC programs. And this morning we heard some really great example. Patrick had a session where our programs are really focusing on the clinical, the KP, the OVC aspects of the platforms that USAID really is like leading on. So I want to make sure that we all continue to think about this in our COP planning, and even right now as you're implementing, how you're linking up all these 3 different programs to make sure that we're reaching like those vulnerable populations. And I say the T word a lot because I support Tanzania, and I think people get kind of tired of it, but they have a really good model where they are prioritizing mother-baby pairs in the OVC program, and they're actually looking at making sure they prioritize high-risk, like adolescent girls and young women who are pregnant and positive, because we know that would be a very tough time for them to kind of deal with, like being younger and then getting diagnosed and then being pregnant and having to take ARVs and disclose and do everything in one day, basically. So the OVC program really has a good opportunity to support these mother-baby pairs. And as of fiscal year 22, quarter 3, we had some good progress in fiscal year 21, but we have almost 27,000 infants enrolled in the OVC program. And what we need to do is make sure not only are we tracking 2-month EID coverage, but following that mother-baby pair in the OVC program until we have a final status determined for that infant. So just some really good examples, I think, that are coming up with prioritizing our support for them. So I got 4 minutes left, and I still have to talk about kids. I'm done with pregnant women. So, well, actually not done with them, but I'm going to move on to kids. I love this saying. We used it this morning. Looking back, but moving forward. Looking back, on the left, we haven't done so great. This is HTS pause by agency achievement, less than 15. We have not been reaching our targets for identifying children for the last couple years. And I know that we're very well aware of that. But I think we need to keep moving forward and thinking about how we're optimizing a multi-mix modality approach for finding children. Index testing is a really, really good modality, but we also need to realize we're not going to find every single child through that modality. So while it should be prioritized, we still need to think about OPD, testing, sick entry points, and honestly maximizing your EID too, because that's really where we should be focusing. On the right, this is data, and we have this new DISAG under HTS index where you report basically all the different outcomes for HIV status for children. That visual is hard to see, but what we're seeing, the gray is basically where we don't have a documented status for a biological child. I'm going to point out South Africa on the bottom. A lot of children are reported where we don't have a known documented status, and that's obviously very concerning, where we have the largest burden of children living with HIV. At HQ, we developed an index training, pediatric index testing training, and we also developed, Christina worked on it too, an adolescent index testing training. And we are available, and it's up on the website to do trainings with our country teams and our implementing partners to really maximize on index testing. And there was some talk this morning. We've got our standard testing modalities to find children, and we need to make sure we're looking at our data and using the right modalities. A lot of interest in HIV self-testing for adults, but we haven't really been talking about how we can use self-testing for adolescents and kids. A lot of good data came out of Montreal at AIDS 2022 from CRS, where they were able to do caregiver-assisted oral HIV screening of biological children to close the index testing gap. And so this is the OraSure kit where you swab a child's their mouth. And so we found really high acceptance and feasibility with caregivers with that approach. And so we really, in COP23, this is something that is going to be updated in the tech cons. We want to start thinking about using this approach for children too, and have them benefit from oral HIV screening at home. I listed Burundi here. Burundi just last year went through an index testing surge, but there was about 6% of children, about 1,746, they couldn't reach. Then they characterized why, those children and why they couldn't reach them, and it was because they lived separately from mom and dad. Like, parents worked over here, children lived over here, children were in boarding school, or for whatever reason, children were separated. And so I think it's an opportunity to think about possibly giving that parent an OraSure kit, and when they're with their child, being able to screen them. I also think there's opportunities to use our community workers, KP and OVC case managers, because maybe parents might feel nervous about screening their children at home. But if I have an OVC case manager next to me and I screen a child and they're positive, they're going to be able to help me as a parent figure out what to do with my child then and get them. So I can't stress enough, we're really excited about thinking about this for children, and if you want to discuss more, we can. But we really need to work with our supply chain colleagues too, our HTS colleagues, our teams, OVC, PEDS, KP, you name it. We're really ready to think about this, this approach for hard-to-reach biological children. Viral load coverage and suppression, the visual on the left, again, fitting way too many visuals on one slide, but adults have higher, no surprise, adults have, they usually do better than us. They have higher viral suppression than children, but the good news is we all know we've got pediatric DTG in almost all of our countries now, and even now in South Africa, we'll be starting soon to start transitioning children. So huge priority for us right now is continuing that transition. Lots of countries are at varying stages, but we're seeing actually our viral suppression results really start to improve and increase, and a lot of our countries are near now 90, 95%. The one area we're seeing a lot of challenges is viral load coverage though, especially for younger kids, less than 5. People get scared. They don't know how to draw blood from a little baby or a child, or use a smaller needle and things like that, and they're getting missed. So we also want to think in COP23, we have pediatric-specific commodities and blood draw kits, and we tried to advocate for this in COP22, but definitely in 23, we want to make sure that countries are procuring the right types of commodities to be able to draw blood for kids and get viral load testing done. Point of care testing, countries are doing diagnostic network optimizations. Please think about pregnant women and children, point of care testing, and how we can make sure we improve their testing as well. And I will wrap up soon. My time says it's up. I don't know when that went off, but I think it was recently, right? Okay. I only have like 1 or 2 more slides, I promise. I love that Tom said death audits. I don't even like saying death audits. It just makes me sad saying that, but we need to think about it. Now that we have TXML data, we're really able to look at like what's happening to kids in terms of mortality and loss, and adults. On the right, all those bars, that's showing TXML number, like mortality data, it's TXML for children less than 5. I was not happy to see Tanzania's 3rd on there. Mozambique and Nigeria, these 3 countries have the highest number of deaths reported for PEPFAR less than 5. Tanzania does a really nice loss analysis every quarter. So on the left, this is from one of our partners documenting outcomes for children on treatment. They looked at the deaths, 77 deaths, and 62% of them were less than 5. And then, as Tom said, it's so important, and we're stressing this with Tanzania now. On the lower left, they did a death audit, and most of them were less than 5. A lot of them died at home. They were on treatment less than 3 months, and a lot of them had no viral load sample done at all. And I'm sure if they had a viral load test and we saw how elevated their viral load was, we might have acted a bit more quickly on that child too. And a lot of the causes of death were malnutrition and TB. But like I said, there's different reasons why this is happening. We need to be doing mortality reviews and death audits routinely in our program to prevent these deaths. And then also, like on the lower right, just shows like get DTG everywhere and for every kid now, ASAP, and make sure that we continue that transition, because that'll really help. And again, I can't say OVC enough, but as we're enrolling mother and baby pairs, USAID's done an amazing job of enrolling more children living with HIV in the OVC program and adolescents. Now we need to show improved outcomes and impact to like continue to have the resources that we want for the OVC program. On the right, really good. Tanzania has gone through a tough time with their OVC program, but we're doing okay. And I say tough time because there were questions about USAID versus other agencies doing OVC programming, but thankfully, I think we are that agency that has comparative advantage and expertise to do OVC programming. But we, in the interagency space, very collaboratively came up with an interagency matrix of indicators to track outcomes for children in the OVC program. And you can see it's across the clinical cascade. We review this together. And I would say for our partners, this is what we've handed to our partners. Clinical and OVC partners are all working together to make sure that they're tracking these indicators and we're reporting them back up. In Zambia, they've decentralized viral load testing, where an OVC case manager goes with a phlebotomist out to one of the family's homes, and they draw blood and they bring it back to the lab and they run their viral load samples. And they've been able to see really good results and improve viral load coverage. And I think it really shows the importance that our OVC programs have such a strong interface with the household and families that we can try to tag on to that and be able to decentralize some of our services in terms of testing, viral load testing, treatment, and other things. And then, yeah, this is my last slide. We talk about Africa a lot. I have to pipe in and put in Asia, and I support India. This is a great model. Deepika talked about this morning in our session. They've got adolescent-friendly services, and we already know adolescents don't do as well on treatment. We have to think about more support for them and tailored services. They can't be just stuck in pediatric clinics with babies and infants and moms and things like that. So India's put together a really nice adolescent-friendly health center through their clinical and OVC programming, and they're offering a really comprehensive package of services there. And what I love is they looked at their baseline data on the left visual, baseline data, they started these models, and now they're seeing better viral suppression results for these adolescents. And I visited one. These kids are just awesome and overall more happy too, so I think that counts for something as well. But I think continuing to think about how you're tailoring your services to different age groups and age bands and what the interventions look like. And then the slide deck wasn't just me, it's a whole branch back in OHA, and we have an awesome team. So we do break down by technical areas in terms of where we support. So make sure if you all have questions, get in touch with your USAID teams. And we're always happy to support and try to share best practices amongst different countries and try to figure out how we support moms and kids. So thank you very much, and thank you for letting me go over time.
Okay. Hello, good afternoon. So my name is Christina Bishop. I am a senior HIV Testing Services Advisor in Office of HIV/AIDS. I'm going to, I think, take a little bit of a different approach. And once again, these also are not all my slides. Like the testing team, especially Liz Manfredini, worked on these. So I'm going to focus a lot on some of the changes that we are seeing in our kind of upcoming COP, and some of the things that have already started, we've already started implementing in terms of policy. And some people, if you were in my last session, you've seen some of this, but I was rushing, so I'm going to try and actually spend a little bit more time on it today. So, okay, a few reminders, and these are things that are in current COP guidance that I have found in some of my TDYs over the last year that people are not 100% aware of. First, those positivity targets for other PITC, if you remember, they were 5 or 10% depending on your ARV coverage. Those are gone. They do not exist anymore in this. I was the one who got to delete that table, and it was really satisfying. And also the index metrics that we had, those minimum things like the 1.1 contacts per person, the 80% of contacts reached, 80% tested, all that, gone. The only thing left in that is 100% offer. So everybody that is newly diagnosed or virally unsuppressed should be offered index testing. And we are still collecting that data, but it should not be used as necessarily like a success metric. If you don't reach that 80%, that is not seen as a failure. If people are pushing back on that from someplace else, reach out to me and I will show them the fact that it is no longer in the COP guidance. So really what we're looking at is that programs should be determining for themselves what that best mix is going to look like. That kind of 30% of new positives coming from index. If that doesn't work for your country, if it should be higher or lower, figure that out for your country, for your context. It is not set in the COP guidance as of this year, as of October. So that's just some like notices in case you didn't read all 800 pages. Okay, so some upcoming changes that we've been talking about. And I had some flyers that I think 4 lucky people actually got. I passed out a bunch earlier and then I ran out. But one of the things that one of the terms that we're now using is that HIV testing should be status neutral. What this means is that we should not be hyper-focused on the case-finding aspect of our testing. We should not be thinking that every test has to yield a positive, as we used to think about quite a lot, or that was kind of the main thing. Obviously, we are trying to find people to link them to treatment, but we also recognize that there is a lot of people that we are testing that are in there for prevention purposes. They're in there because they're testing for PrEP, they're in there because they're testing before VMMC, or for PMTCT. There's a lot of reasons that people are testing that might not be us trying to kind of find that positive. It might be so that we can link that person either to treatment if they're positive or to prevention if they're negative. So it's kind of a more whole person approach. So it's actually, it's kind of a complicated name, but a fairly basic topic. We're testing people because we want to link them into HIV services, whether those services are prevention or treatment, depending on what their status is. And I will say, actually, I'm going to note quickly, we've made it into the draft PEPFAR pillars. I do not know if it's going to hold in the final version, but it is currently in the draft. So just kind of to show some of this, for this last year, 24% of our testing was within just 3 prevention indicators. So we were already doing this, but we didn't really have the language in PEPFAR to really talk about it. So, and this doesn't even count testing for PrEP, right? Like in these 3 indicators, because PrEP is usually folded into other PITC. Okay, another change is how we're thinking about prevalence. So country prevalence, let's say you've got a prevalence of 20% within your country. You oftentimes would hear people kind of giving pushback that you should have a higher positivity or yield because you've got a 20% prevalence. But it's not taking into consideration the fact that many countries, lots, if not most, if not almost all people that know their status are on treatment, right? So we've got the treatment-adjusted prevalence, and this should be a formula, so like add a line between those two. Imagine it's division algebra. So your treatment-adjusted prevalence is your estimated number of PLHIV, adult PLHIV, minus your PLHIV on ART, over total adult population minus adult PLHIV on ART. So you're taking out those people that are already on ART from your formula. What this means is that in almost every single case, our PITC yield is it's less than what your more than what your treatment adjusted prevalence actually is in every country except for Mozambique and South Africa. So actually this is a big enough thing you can actually see it here. It does have a laser. So you can see here's the prevalence countrywide. So we take Lesotho, for example, 20.7% prevalence, but when you take out all those people that are on ART, 4.6% of those, of that population. And right now, 4.6, we've got an 8% positivity within our PITC program. So we're actually doing really, really, really well there, right? So the 2 places where there is room for improvement, Mozambique with a 3.6% treatment-adjusted prevalence, PITC is about 3%, and South Africa with 7.4%, PITC is about 3%. So kind of just a new way to think about prevalence. Okay, next. We've got music going. Risk screening tools. If you have talked to me in the last year or talked to several of us on the HTS team, we have started really trying to push this decreased emphasis on the use of risk screening tools. There was a huge push towards the use of risk screening tools, and what we found, and I'm sure anybody who's looked at their data has noticed this, is that what that means is that we were not testing a lot of people who probably should have been tested, and while we might have increased our positivity in some settings, it also meant that we were finding significantly less positives, meaning that those people were lost because they didn't pass the risk screening tool. So we are de-emphasizing these. Risk screening tools should be validated, and I will say, for adults, there is not one validated tool anywhere in the world. If anybody has an exception to that, we would love to hear about it. We have been trying to find one. There is none. All the ones who have attempted to be validated have failed in their sensitivity or specificity, so we have not had any success in that. They also should screen in and not screen out, meaning you're trying to pull people into testing, not push people away from testing. So at this point, we would say just if you're going to use a screening tool, really look at that screening tool. Is it benefiting your clients? If it's not benefiting your clients, do you need to be using this screening tool? Are you missing people because of it? If the answer is yes, we are missing people because of it, please de-emphasize the use of risk screening tools. The question I often get is, what about commodities? That is a question that the country team's going to have to figure out with what they're going to set their targets for. But it is something that I know some countries have struggled with this, but you need to look at kind of where your, how many tests that you're going to have to do without this use of risk screening tools. But we really do not want to be losing people. I mean, a test kit is like 80 cents, 60 cents, whatever. Like these commodities they're worth it. If we are losing people because of the use of this risk screening tool, it's just not worth using them. Okay, next, self-testing. Self-testing should be scaled. Most countries are doing this. Lesotho, like really doing this. The red is a percentage of self-test as all of testing. So Lesotho, Eswatini, Malawi, Zimbabwe, Vietnam, self-testing should be scaled. Do I have them on me? Okay, I'm gonna pass them around, yeah. Pass those around. Okay, so what I'm passing around here is a new blood-based self-test. Some people might have seen it because I've passed it around now in 2 sessions. A new blood-based self-test that is $1. This could be a game changer. The commodity prices for self-tests are going down significantly. I mean, the OraQuick self-test is, I think, $2.30 right now. This one is $1. I will say this one is a bit complicated to use, so that is something you'd have to take into consideration. But if it's something you're interested in, please reach out to your HTS advisor. It would obviously have to be approved by your country, but we do have now access to dollar self-test kits. One other thing to note is that self-test, there is, I think, a lot of concern of how do we then collect this data. We're doing self-test to try and pull people into services. If we are forcing them then to give us the results or to collect a whole bunch of personal data on them, we're going to be losing some of those hardest to reach people. So while you can ask for results back, a lot of countries do this through messaging, some sort of, here's a phone number, call us with your results, or they text the person. That should be voluntary. Nobody should be forced to give any sort of results for self-testing. The idea is that we are pulling people into services. We have to give them the education and the understanding when they get the kit that this is where they can now go for services. They need to have that information, but we do not want to force them to give us the results or to give us personal information. If they can voluntarily do so, but please don't force it. So self-testing should continue to be scaled. We should be really decreasing that data push. You want to be focusing on engaging. Actually, Vincent, some of you probably know Vincent Wong. Earlier today, we were talking, and he said, nobody's like overly obsessed with whether or not we get COVID results from at home. at-home test when you're taking that. Like people, the assumption is that if you get that positive result, you're gonna take care of yourself and you're gonna do what's best for you, right? So we wanna think of it in that same way. So we are scaling self-testing, but self-testing can be used both for case finding and for prevention. In fact, on my next slide, I'll talk a little bit more about that. There's actually a lot of really, really innovative ways to distribute these. Private sector distribution is one way that can be scaled. And then really we need to start advocating for regionalization of the storage and distribution of these self-test kits, because I think that's one of the ways we're going to be able to get them out to a wider population. And so this is kind of one of the newer things. It is the WHO recent guidance has said that you can use a self-test kit for PrEP, not for PrEP initiation, but for PrEP continuation. So instead of somebody coming in every 3 months, you can give them a self-test kit, you can send them home with that self-test kit, tell them to test in 3 months, and that saves them the trip to the clinic. It saves the burden on the clinic of having to test that person, saves that person the trip. So we can use it for continuation, reinitiation, and just effective use. So if you are finding that you're having a fairly high PrEP burden of testing, and I've seen this in places where you look through the register and like every 10th test is somebody who's coming in for PrEP, this might be a way for you to kind of decrease that. And also, it could very well help somebody stay adherent to PrEP because they don't have to keep coming back to the clinic in order to get that. You can give them the self-test instead. So this is fairly new guidance. It used to be that you could do this, but blood-based, and they have now expanded this to oral fluid as well. That might be my last slide. Ooh, it is. Okay, thanks very much.
Hi everyone, I'm Patrick Hazelton from Office of HIV/AIDS, Senior Key Populations Technical Advisor. I know we've been talking a lot at you, and I promise you're going to get some time for questions and a little more exchange. I'm the last presenter today. I did have a colleague over lunch who was telling me that in their region they've mastered KP programming, which I was excited to hear. That they're meeting a lot of PEPFAR benchmarks, but I'm probably going to take a similar approach to Christina today and think, what's the frontier? What are the next steps? For those of you who've been working on KP programs, there have been some traditional ways of looking at KP programming that we're also trying to move beyond and try to think a little bit more creatively. And even a little more cross-cutting. Mina talked a little bit about service integration across KP OVC programming. Tom mentioned beyond HIV health services, optimizing differentiated service delivery. And that's all part of similar approaches for KP that I'm going to talk about today. Also part of this health equity and sustainability framing that we're seeing as part of the new PEPFAR strategic direction, Pillar 1, which Mina mentioned. So yeah, we're trying to think creatively about how, for those of you who think you may have mastered KP programming or you're just looking for new innovations, this will give you a little bit of food for thought. Big thanks to my colleagues back in Washington for helping to prepare some of these slides. All right, so starting out with a bit of a success story, this one is about some really excellent KP local partner performance that our team back in Washington is tracking. So we can see here that KP local partners are meeting and exceeding targets and certainly matching, if not exceeding, the performance of central KP mechanisms. So I think that's important to note. We're here at a local partner conference and certainly plans to keep scaling up local partner transitions throughout the world. And at least from the KP perspective, definitely we're seeing a lot of success and a lot of hope, I think, for continuing those trends. All right, and then shifting gears a bit, I talked about this a bit at this conference last year, that again, just really emphasizing every year we get a more convincing evidence base that the global HIV burden really lies significantly with key populations. We don't necessarily see this in funding. We know that KP work is chronically underfunded, and that's for a variety of reasons, political reasons, historical reasons. But the data increasingly is convincing. This is from a 2022 UNAIDS special analysis report. 70% of new HIV infections last year were estimated to be among KP and their sexual partners. And we can see that this trend holds true across world regions. So all world regions outside of sub-Saharan Africa, have a KP-concentrated epidemic of 94%. Even within sub-Saharan Africa, the majority of cases are expected to be among KP and their partners. So this speaks, I think, to the urgency of reaching KP and their partners, that we have to be keeping that framing in mind, but we're also redefining what key populations look like. KP aren't necessarily, siloed into the KP types traditionally we've thought about: MSM, FSW, TG, PWID. There are intersectionalities between groups. There are KP who show up in different ways depending upon their political context, depending upon where they are in the world, and we want to be more sensitive to that, and we want to provide services that meet their needs and have this differentiated service delivery approach as a result. So again, for those of you who joined this morning's health equity session, we talked a lot about this, and there's some new ways of thinking about the framing of KP within this equity model and an equity and sustainability model. So on the left, thinking a little bit more upstream, definitely the equity lens really emphasizes a focus on structural issues and human rights, the idea of heterogeneity of risk and prevention impact, really a renewed emphasis on prevention, and hearing Ambassador Nkengasong talking more about the importance of prevention has a particular importance for meeting the needs of KP. Even some of the metrics that we're using globally with UNAIDS and WHO, like the UNAIDS 95 targets, are being redefined to be more sensitive to the needs of subpopulations. And this is cross-cutting. This isn't just KP, but KP are certainly included. It also includes children living with HIV, adolescent girls and young women. The 10-10-10s helps us to think about structural barriers and making sure that those are being measured. And even though PEPFAR has not historically been good at capturing those indicators, we do have custom indicators. We do have ways of harmonizing with other donors, with global funds initiatives, with breaking down barriers for how to potentially better capture some of the legal and social barriers that are faced that prevent an enabling environment for HIV services. And then, of course, as I mentioned, the PEPFAR Pillar 1 health equity is also really driving a lot of the conversation for PEPFAR heading into this next COP-ROP season. And then differentiated service delivery, and then HIV prevention, integration, innovation, all some of the ways in which these elements are being operationalized. All right, so on this slide, it's just kind of another way of viewing some of these ways in which we're seeing operationalization of these factors. But I did want to talk a little bit about this morning, some examples we had from the health equity session of these in action, of integration, of DSD. We heard from Cameroon a good example, I think, of KP OVC integration that was really strong. We heard from the Accelerate project in India, a really inspiring message from young adolescent injecting drug users, from taking a more family-centric approach to meeting services, and again, this getting to the intersectional kind of approach to looking at KPs, especially younger KPs who are often traditionally underserved by our programs. Nigeria also talked a bit about a KP PP program that addresses stigma and discrimination and has a focus on empowering gender minorities, female injecting drug users, incarcerated men. So again, these intersectionalities, these KP groups that aren't traditionally looked at, and also similar to what Tom mentioned, an increased focus on mental health, psychosocial services that PEPFAR has not traditionally been very good at supporting. So this is a similar slide to what I also presented last year, again, but re-emphasizing the importance of structural interventions. We've seen many KP programs benefiting from the Human Rights Grant Program Awards over the years, and we also see a push for social contracting, social enterprise initiatives. And finally, we continue to see successful efforts to meet KP community needs, scaling support for hormone therapy, STI treatment, mental health, psychosocial support. All right, I'm about halfway time here. So I'm going to shift to the new WHO consolidated KP guidelines for KP. All right, we see in this diagram some of the intersectionalities for stigma, criminalization, violence, unemployment, poverty, some of these upstream factors to be focused on. Also some of these intersectional factors such as gender, race, disability, and education. And then also recognizing that these are all potentially detrimental to access to some of the prevention testing and treatment services, and also the heightened vulnerability that we see manifested in biological and social factors that are relevant to KP on this diagram. And then this is a potential continuum of social services, of essential services for KP. Again, starting on the left with these enabling interventions, some of the structural barriers, human rights approaches that we talked about previously. And then heading towards health interventions and this integration between HIV, viral hepatitis, and STIs for KP, which again have traditionally been siloed, especially for KP, but thinking through some of the ways in which these programs can be integrated and making sure that there's broader access to prevention services, including access to PrEP and PEP for HIV and STIs. The use of DoxyPEP has come up, exciting new evidence that DoxyPEP can be used for prevention of STIs, including chlamydia and gonorrhea. Also addressing chemsex, which has come up as a priority issue in a number of KP contexts. And then also heading towards the right here, some of these critical broader health interventions that go beyond what's traditionally been provided in KP programs, support for anal health, alcohol substance abuse, gender-affirming care, and again, similar to what Tom said, mental health, psychosocial support services. All right, and I want to conclude also, I thought this was a really interesting finding from the Consolidated KP Guidelines. It's a bit of a counterintuitive point, but I think it's particularly important because it's often frequently misunderstood, this importance of looking at behavioral counseling interventions in a certain way. So for the first time, the guidelines state that counseling behavioral interventions that aim to change behaviors for KP have not been shown to have an effect on HIV, viral hepatitis, and STI incidence, nor on risk behaviors such as condom use and needle sharing. So what does this mean in practice? It's a bit of a subtle messaging shift, but we know that counseling KP with the intent of changing sexual practices or reducing drug use should no longer be recommended under the new guidelines. And again, this is coming in the context of what we know is in many contexts, the continued harmful implementation of counseling interventions that seek to promote stigma and discrimination, even violence towards KP. So this is the context where we talk about things like so-called conversion therapy for LGBTQI+ people, abstinence from drug use and cessation of sex work, all of which are clearly contraindicated by the new guidelines. However, this is not to mean that there isn't still a purpose for counseling in KP programs, but the purpose of the counseling should be around information exchange, education, empowerment, for instance, letting KP know about their ability to advocate for and access to PrEP, condoms, needle exchange services, and these should all be conducted in a non-judgmental manner with other prevention services and with the involvement of KP peers. So again, it's a bit of a subtle shift, but I think we've talked a lot about social behavioral change as a way forward, within HIV services, but it's a particularly sensitive area for KP, and again, it takes on a political importance in context of high stigma and discrimination, and it's another way of thinking of it in a more positive sense about how to provide services in a non-judgmental manner, and how to provide services in a way that empowers people to have more access to information so they can take care of their sexual health and their other sort of broader health, including mental health and psychosocial support needs. All right, so I have been asked to become the MC for our discussion and questions section. So this will be an opportunity for you to be also engaged, and again, this can be for any of us, for all four of us, and we'll come on up to answer your questions. But I know we've talked a lot at you, but happy to take questions from the audience about any of these presentations. Yeah, and do we have a roving mic that we can use?
Right here. If you want to come up.
Oh, yeah.
Hello.
We have a roving.
Okay. Now, is it on now? Okay, great. My question is for you, Mina, and for you, Christina. Self-testing in children is something we've been dying to explore because it's just got so many opportunities. But two of the things that we sort of finding quite challenging are, one, it doesn't seem to be validated, or there seems to be a validation process that still needs to happen for children under 12. And I mean, I don't know if it's a formal validation, as in, does it actually work for children? I think it will work, but there seems to be some sort of difficulty around that, especially here in South Africa, that it's not validated. And the second problem that I picked up at IAS was the number of false positives reported by caregivers. I think that was, I mean, obviously I think it's more to do with, you see one positive line on the test and you think, okay, this is a positive test. So I think that, I was just thinking how I would feel as a caregiver if I thought my child was positive, even for 24 hours or even for, so those two things are quite a challenge for us. So if you've got any advice there, that would be great. Thanks.
Sure, I can start. Yeah, Jackie, we can follow up, but it had been, that's actually why we've been pushing it more, because it was actually WHO pre-qualified and validated, and there's like a whole update to the self-testing, like for OraSure, basically. That's the only one that we can use. It's the oral HIV screening test kit, whatever we call it. That's the only one that's okay for use in children from 2 to 12, basically. And it has been WHO like approved, PQ'd and everything. I'm learning about South Africa. I know you have your own processes here to use products and things like that, so that might be the other hurdle. And I think you bring up a good point. Also, policies have to be there to allow for this. I say in Tanzania, I don't see this happening because they really want to use more traditional, like doctors and nurses and like counselors do facility-based testing, and there's nervousness about putting an oral screening kit in the community and nobody supporting parents and things. So I think it depends if you have the policies too, but we can talk more and I can share that that it has been validated, and it's based off of a study that was done in Zimbabwe by like Rashida Farand and that whole group where they validated it, I think in like 2 to 15-year-olds. Yeah, that came up in Montreal. There were, basically for everybody else, there was, children were screened in this, what CRS, this implementing partner, had presented in Montreal. A set number were screened positive, but when they had confirmatory testing, they were negative. So there was a high number of false positives, and that came up because that's really concerning when you've got a parent at home with their child and it's a false, the numbers of false positives was an issue for sure. I think the investigators did say that their numbers were smaller and that if they had increased their sample size, that it would have corrected and they would have had a lower number of false positives. But right now, WHO is reviewing all of this evidence and deciding on the guideline update. And I think that's going to actually be the sticking point on it, on looking at like, okay, is it worth it actually putting it out there? And they've had to think about this for all testing, right? Is it worth it putting it out there when we've got like the only evidence we have is this one study that shows this high false positive rate? So I can't get into like the real details of it, but we can talk about it a little bit more.
My name is Ben Chirwa. I'm from Zambia. We work in 3 of the 10 provinces in Zambia on the clinical cascade. My question, I think, to Tom, and maybe to you as well, I noticed that Tom talked about integration in terms of clinical cascade, but we noticed that in the new RF, the activities are separated. So it means implementing partners are fragmented. For instance, the program I was on in the same area, our activities included key POPs. But the new project is that has been taken out and it's given to a different partner. And we have to work out a mechanism of basically service level agreement to do this. However, is that the progress that we made working in the key population means now has stalled because we're no longer doing that. And we cannot even report on that because there's another implementing partner doing that. How do we get to basically integrate, like you were saying? Thank you.
Sure. One, Dr. Ben, it's great to see you again. You actually look younger than the last time I saw you, which was pre-pandemic. So I congratulate you on pulling that off somehow. One, it's a great point. And this is actually something that you're probably going to need to work on with the USAID team in Zambia. You know, in the end, we really want to make sure that the services are right for the clients. I think In the general population world, we've actually learned a lot from the way that our KP colleagues have gone about differentiated service delivery and really tailoring the services that clients need. But if you have, a given 10 people who identify as a member of a key population group, the drop-in centers are a great example. 7 of them may want to get their services there. 3 of them may be fine, actually, and prefer to receive services, say, within an outpatient department anonymously. And it's fine wherever they do it, as long as we're providing the service that they need. I can see the challenge that you're coming up with. If those 3 then went to the outpatient department and got HIV services there, you wouldn't be catching them or reporting them as key populations so that we know that all 10 are receiving the services that they need. That's really a problem that we need to fix on our end as USAID, working in collaboration with the implementing partners. We don't necessarily want to then, force the people to go into one service or the other so that we can report it correctly. We need to figure out a way to report it correctly without, while providing the services that the clients need. So I think as we come up with some of these, some of these issues that are going to pop up, especially since, and I'll be perfectly honest, as USAID, we haven't really integrated our programming where we have, say, HIV funding, malaria funding, MCH funding, all that well either. We have things that we can learn. We need to have that constant dialogue, I think, with you as IPs to see where is there workarounds that we can do, for instance, to make sure that you can report it. It may not count towards your targets, but it helps us better understand how we're serving the KP clients. What's the best format for you to do that easily in a way that's not going to, take up a lot of time and resources, but still provides us with the information to better serve you, who can then better serve the clients. So I'll be honest, I don't have a good answer for you, but I think that this, and within this integration piece, you've highlighted a really important thing, is that this is going to be a work in progress where we stumble a few times before we get things right. And I think that constant dialogue is going to help us do a better job with that. Even beyond the example that you did, I think, a lot of our integrated services need work. Patrick, would you like to add to that?
Sure. Yeah, no, just the Zambia context, this is across USAID partners within the agency. Yeah, no, so yeah, as Tom was saying, I mean, integration is a work in progress, and the idea is we certainly wouldn't want to force any clients to leave their current program, go to a KP-specific program. So some of that is on our side, working on the reporting piece. Again, potentially being able to report those existing KP who are in the service, still being able to include KP in this integrated program. But yeah, not necessarily having the same focus on targets, but some of that is having this additional collaboration potentially with the partners, having those MOUs, making sure there's some sort of worked out agreement that potentially the partners also could see a benefit to having that integration. And again, I mean, that's something, yeah, country by country, I think working out with the mission colleagues and the individual partners being able to see what potentially could make sense. Because I know there have been some painful shifts between partners where there's sort of fighting over reporting and who gets which KP and that sort of thing. But ideally, there is a way to work it out where there actually can be seen to be a net positive for both partners, right? When it seems like you're able to get the people to go to the places they actually want to go, and then you figure out the reporting as a secondary sort of priority.
Can I go? Okay. There's a question online. Okay.
So sorry, there's a question online that we just got, so I'm going to just quickly do that one, but it only takes a second. So the question online was, you spoke about doing away with targets for other PITC and the status neutral testing services. What does that mean in the context of HTS test target that we still have? Will we still have to achieve these? So it's not that we've done away with the targets we've done away with the positivity target. So it used to be in the COP guidance that there was an expectation that that other PITC would reach either 5 or 10% positivity or yield. That is no longer in there. So there are still targets for testing in other PITC, just that particular target is not there. So what that means is that you look at your program data, you look at things like your treatment adjusted prevalence and see what you think a reasonable target would be for your PITC program, for your other PITC program. So that's what that means. So it's not that there's not going to be targets necessarily for positives out of that. There's just that expectation of a particular positivity out of that particular modality are no longer there. So hopefully, Stella, that answers your question online. Please.
So actually, we went to the first question that I had to you regarding the treatment-adjusted prevalence rates. So you look at South Africa, Mbata and I from South Africa, and the 7% that you talk about, the last time we hit 6% yield was probably 3-4 years ago, and we have never been there. So we wonder where the 6% that we are expected to find in yield will ever come from, because we've been 2-3% as an OU for a very long time. So I don't know if you can explain where that probably comes from and how we can bridge the gap. Then the second question is to Mina and Tom. I think, Tom, we've discussed this before. When you talk about mortality and the need to have mortality audits to try and understand the causes of death, what do you think is an acceptable number of mortality or percentage mortality rates that we should have as a program to know that we actually have a problem? Because people are going to die, but then what number should prompt us to actually investigate further? I'll give an example in our context where we have mortality rates of, in a quarter, more than 6,500. How we don't have capacity to even do these audits. We are now in the process of trying to do one in one province, but the amount of work that it requires is just too much. So maybe your guidance on this would be appreciated. Thank you.
Okay, so I'll start with your first question. So the treatment-adjusted prevalence is just a way of thinking about what your kind of goal is. It's South Africa and Mozambique are just the two kind of outliers there that kind of are testing under that. But yeah, there's not necessarily a tie for your targets for PITC to that, but it is something that you should be looking at. It is a way of thinking about how you're actually targeting that program, who you're actually testing, and whether or not you should be figuring out a way to kind of scale up your testing to test a different population, or possibly optimize in some way for that particular population. Sorry, I seem to be losing my voice. So yeah, I hope that answers your question a bit, but I will pass it on.
You want to take first?
You want to go first? I'll follow.
No, Butts and I, actually, we don't really have a good number. I think that's one of the big challenges here. In theory, we could say, well, yes, you should have no HIV-related deaths. But let's be realistic. That's not going to happen, certainly in the early days. If 15% of people are truly still coming into services with a CD4 count of less than 200, there are going to be some of those folks who do pass away before we're able to really serve them correctly. I think in this next year, the focus of these death audits, and we really do got to come up with a better term for that, really should be around just understanding, again, where the system's not working and what those patterns might be. For instance, if you have 10 deaths within a region, and this, don't let the perfect be the enemy of the good. If maybe it's just one site, you do it twice a year, and you just try to take a look at the deaths that happen there. Maybe you do it in a handful of sites in a given district, wherever you think is best. Any information is better than a lack of information in this case. If you have one client who comes in with a CD4 less than 200 and dies within 2 weeks, okay, well, you realize, well, we've got one client who failed because there was some sort of barrier for them to get into treatment. But if all of a sudden that's 4 out of 10, that tells you that you really need to work on that. So I think just doing it gives you a little bit of information, and you're going to get some deaths that are actually HIV unrelated. I know, and Butts and I, you were probably involved with this too. We did this with Right to Care in South Africa. They did a really nice, very detailed audit of all the things that went into the medical care that they could discern for people who did pass away. And sometimes it was something that seemed very HIV unrelated, like a deep vein thrombosis that caused a pulmonary embolism. Still helpful to know, like if this happens to occur in more frequency with some clients, we have to ask why this might be happening. But just, I think at this stage, benchmarking is going to be real hard because we don't know what a benchmark is. It might be a little bit easier for kids, but maybe not. And Mina can comment on that in a minute. I found the malnutrition piece really interesting that Tanzania did. But I think just fact-finding, and again, even just a handful of audits, maybe once a year, maybe twice a year, maybe once a quarter, whatever you think is best, will be really, really helpful. One, to figure out where we're failing, and two, to understand those patterns of morbidity and mortality that we need to start integrating services better for.
Thanks, Tom. I agree with everything. And I think exactly like mortality reviews or death audits can be really time consuming, but some type of sampling approach. And even like the health facility staff, maybe once a month or once every 6 months reviewing their records and saying, okay, why did this happen? And something more even informal like that, so they can better understand how they might need to shift their services around. And I think what Tanzania did was they took that mortality data and they were able to disag it by age. And I think looking at your data that way helps you really figure out who's dying. And I will say, my answer has to be, like, as a pediatrician, no death is acceptable, I think, for any child that's infected with HIV, but I know that that's a really tough, ambitious thing to achieve in our program. And I do think, though, we, like Tom said, we have to look at our trends, and now we have this rich TXML data, and just make sure that we keep reviewing that and seeing what we're doing with that. It's like, we've achieved these really high viral suppression rates, but is that actually program success when you still have, you know, the number of deaths that we were just seeing in Tanzania and like other countries too? So I don't know if that like helps with an answer, but just to add on a little bit to what Tom said around that.
Well, the next person comes up, I'll mention, I love that Tanzania example because you have an answer in there. If 40%, please come up, are acute malnutrition in the under fives, as part of the advanced disease package, we actually need to include food supplementation. We used to do a lot of this under PEPFAR. It got kind of disfavored, but there are a lot of people, adults and kids, where that is probably an important thing to include in an advanced disease package. So, please.
Yeah, thank you, all presenter, for the well-informative presentation we had this evening. My concern is not a question, but maybe more of suggestion to Christine on the emphasizing the HIV screening tool. From our perspective in Tanzania, when we started with HIV screening, from the policy whereby test all and the PEPFAR that we have to have a focus testing, it had kind of a bit of struggle at initial, but at that moment now we see the uptake, even the governing the ministry and PEPFAR now they are aligning. So now coming like the emphasizing might be not, we can go and start it, but might be contrary to the ministry or the governing. To what I could advise now, we have already identified that the gap with the screening tool are not being tested. Probably PEPFAR, USAID, if we can come up with a plan in the first and the testing, and probably come up with the testing individualized to every country perspective, so that instead of de-emphasizing, have that kind of a message, is we kick on having the tested HIV screening tool. I found that could be more better than what has been suggested. Thank you.
Yeah, you're not the only country that I've had conversations with that this has been kind of rolled out at the national level by the MOH, and now we're saying to kind of pull it back. You're not the only one. I will say that that's one of the reasons that we're doing this, and it is kind of an interagency discussion and this is not necessarily just a USAID thing, it's across PEPFAR. We're in remarkably good alignment on this, that we need to de-emphasize these. And part of that reason is just because we're realizing that we're missing a lot of people, and that these tools are being rolled out in ways that they were never intended to be rolled out. Like I said, VMMC being one example where I know of at least one country where they were using a risk screening tool, and if somebody was going in for VMMC, not testing that person if they didn't screen as at risk. But then we were finding that young men were having VMMC, and then were testing positive a few months later, and had probably been positive that entire time. And so they underwent this procedure that was really not benefiting them, and it isn't 100% risk-free. So there is situations where we really need to de-emphasize these, but I do get your point that there are a lot of ministries that have already kind of taken these up. There are some countries that are looking at ways to kind of modify these tools. Like I said, none have been validated. If you've got an example of one, we would like to see it because not one has been validated. But I know that some countries are looking at, can we kind of use a flow chart of if this person fits into the, like we can ask these kind of questions instead of a yes, no, but who do we actually want to test? I mean, you don't need to test the 75-year-old woman who's been married to the same person for the entire time and who has not had another sex partner in her, the last 50 years. Like, that is not somebody that we're looking to test. But there might be situations where you do want to test a 75-year-old woman, right? Like, that there's obviously going to be situations where that might change. But how do we actually do that without missing a whole lot of people? That's, I think, where the key is. And unfortunately, none of these tools seem to do a really good job of dealing with that situation. I think we have 20 seconds left. Is there one pressing question? I saw your hand, so if you can be really, really, really fast. But we have actually no time left, to be honest, but we're going to get kicked out really soon.
It's a pressing question, but yeah, so it's for you, Christine. Mainly it's Team OVC and usually like advocating for OVC partners. I'm from Zambia. Yvonne is my name, USAID Cup 2. So it's about testing and now what we've learned from you. And because we use a family-centered approach and we are really like best positioned to provide testing. The problem we have and the layer that we have to overcome is that we are not allowed to test as OVC partners. And we have to work with clinical partners, which has been good, but sometimes we've got these families because of the family-centered approach, and we can easily get to the mother. We can easily get to the siblings. We can get to the PID and test. So in COP24, is it? Can this be reconsidered to just, probably not even just give us the tools to help us test, because we're really better positioned. And another thing is about PMTCT. We have a subpopulation of, HIV-exposed infants. But if we can even be reaching these mothers early, like when they're just pregnant, and especially with the less emphasis on those that are HIV positive, we can contribute highly to the PMTCT cascade and helping because we reach them in the communities.
Okay, I'm getting a time's up thing beeping at me, so I'm not gonna, and that is a very complicated question. So, but let's talk. I think that you're, once again, not the first time that I've heard that, so I think there's a lot of conversation. Yeah, so we can have a conversation about it offline because we're being beeped at. Thank you, everyone, and please enjoy the rest of your sessions today.